I am in charge to talk about test your knowledge on scalp clinical cases, but first I have to thank you for the kind invitation, Dr. Stéphanie Leclerc-Mercier and Beatriz Santana. Thank you for this kind invitation. And I will introduce my presentation with this healthy 14-year-old Caucasian boy complaining of intense hair loss, severe itching and scaling of the scalp. Although it was not essential in this case to see the scales, we performed a trichoscopy and thought of Psoriasis amiantaceae as the main diagnosis. A few months after the treatment, the patient evolved with complete hair regrowth. So the first message is, usually if we treat the scale and erythematous conditions associated with hair loss, hair regrowth tends to occur. In clinical practice, we can observe a close relationship between the scales inflammation binomial and hair loss. So let's move to case 1. My case 1 is a healthy 28-year-old Caucasian man complaining of progressive hair thinning since age 21 without any other associated symptoms. He used low-dose oral minoxidil and oral dutasteride with progressive improvement. This is before and after pictures after 6 months of treatment. So when trichoscopy was performed, it was possible to observe yellowish signs compatible with increased sebum, inter- and perifollicular scales, erythema, and arborized vessels. The patient was surprised to see seborrheic dermatitis on trichoscopy, which he was clinically unaware of. These 2 recent articles address a possible relationship between microbiome changes, seborrheic dermatitis, and hair cycle alterations. It makes sense. So it makes sense to try to find and treat subclinical seborrheic dermatitis in patients with other hair loss complaints, even without symptoms. In trichoscopy, we should look for inter- and perifollicular yellowish scales, yellow dots compatible with the presence of sebum in the follicular infundibula, and vascular pattern, mainly these arborized vessels. Regarding vessels, usually they are thin, but sometimes large caliber vessels can also be seen. So there is the first question to you, to the audience. Let's move to the slide, maybe 10 seconds. And okay, this is it will appear for you how to use the keypad, okay? And you have to press the button if you want letter A, B, C, or D, but you don't have to press OK. Everything is fine with that. Okay, so let's go to the question. We have seen that the vascular pattern is important in inflammatory disease of the scalp. However, the vessel thickness must also be considered when performing trichoscopic analysis. In which of the clinical conditions below can large caliber vessels be seen on trichoscopy? Letter A, or number 1, rosacea and basal cell carcinoma. Letter B, or number 2, lupus and dermatomyositis. 3 or C, cutaneous metastasis and atrophy due to intralesional steroid infiltration. And 4 or D, all of the above alternatives are correct. So I will give you some seconds to think about it. Votes. Let's go. Okay. So, most of people here in the audience chose all of the above alternatives are correct. So let's see if everything is fine. Let's go to the... Okay, you were correct. All of the above alternatives are correct. So let's see some trichoscopy images. Here we have an image from of rosacea or rosacea with several large caliber vessels that we can see. Here in a basal cell carcinoma with large caliber vessels crossing the lesion. That's the tip. That's the important point to know. In lupus, discoid lupus, we can also see dyschromia, fibrosis, and follicular plug, as well as in dermatomyositis, where we can see perifollicular scales associated with the large vessels. We can also see large vessels in cutaneous metastases, as reported by this interesting article coordinated by Professor Pirattini in 2019, and atrophy due to intralesional steroids infiltration, as published by Brazilian colleagues. So let's move to case 2. Case 2 is a healthy 51-year-old Caucasian female complaining of diffuse itchy scalp. We can see the presence of visible erythema in the middle hairline. Clinical examination shows scaly erythematous plaque transgressing the occipital hairline, consistent with psoriasis. In trichoscopy, shows yellowish, white, peri- and interfollicular scales on an erythematous base, supporting the diagnosis of psoriasis. After 4 weeks using calcipotriol plus betamethasone gel every night, she partially improved from the symptoms and lesions. At this point, Dercus anti-dandruff shampoo for daily use was introduced, and it was possible to notice a significant improvement in the desquamation in the before and after picture. This patient has an overlap sebopsoriasis and showed benefits with the association of the shampoo and betamethasone gel with calcipotriol. This is an interesting article about how to optimize trichoscopy for evaluation of scalp disease, published in Skin-Dependent Disorders, and it shows that pressing the dermoscope, the arborized vessels of seborrheic dermatitis disappear, and the twisted red loop vessels of psoriasis usually persist. So the trichoscopy clue is, in the same spot, using mild pressure or strong pressure, you can see different situations. So when performing trichoscopy, it is important to pay attention to the pressure imposed to better analyze the inflammatory condition. This article shows that the altered microbiota in patients with inflammatory conditions transgress the scalp. Therefore, the author suggests that therapeutic shampoos are also used beyond the hairline. Let's move to the second question. More few seconds. Okay. So when we are examining a patient with clinical suspicion of psoriasis, it's very important to consider other possible differential diagnoses. What diseases would be examples of this differential diagnosis? So the first one, tinea capitis and psoriasis amiantacea. 2, lupus and dermatomyositis. 3, seborrheic dermatitis and allergic contact dermatitis. Or 4, all of the above alternatives are correct. You can vote. Perfect. We can move. So, almost all colleagues here in the audience think all of the above alternatives are correct. So let's see if it is the right answer. Okay. Yeah, you are all right again. And so let's see the differential diagnosis that we can have in these cases. So tinea capitis. Tinea capitis on trichoscopy can reveal scales in a barcode pattern. We can also see this kind of dystrophic hair that is called coma hair or corkscrew hair. In Psoriasis amiantacea, we can see scales adhering to the hair shafts, as well as discoid lupus can be a differential diagnosis, as well as dermatomyositis, contact dermatitis, and seborrheic dermatitis. So the last case that I want to share with you is regarding a healthy 40-year-old Caucasian male complaining of diffuse hair thinning associated with symptoms such as pain, burning, and scalp hyperesthesia. So I want to highlight this concept that's called trichodynia. Trichodynia refers to the painful sensation of the scalp related to the complaint of hair loss. The main symptom is pain, but it can also be associated with burning, itch, or dysesthesia. Although the clinic looks like androgenetic alopecia, trichoscopies show, in addition of the variability of the diameter of the hair shafts, signs of lichen planopilaris, as peripyral scales and erythema. So, fibrosing alopecia in a pattern distribution, that's called FAPD, is a relatively newly recognized form of scarring alopecia, sharing characteristics of both androgenetic alopecia and lichen planopilaris. This is a great review article about this topic, and it says that FAPD affects the androgen-dependent scalp, and it's typically associated with hair follicle miniaturization. Trichoscopic evidence of follicular inflammation and fibrosis are important to identify the condition, and a dermoscopy-guided biopsy can confirm the diagnosis. Unless recognized, clinicians may misdiagnose FAPD as androgenetic alopecia associated with seborrheic dermatitis. One more image to fix this concept. And so, let's go to the last question. You moved. Okay. So, in desquamative conditions, not yet. Okay. In desquamative conditions, details of the scales can help us make the correct diagnosis. Regarding the scales in the hair and scalp diseases, mark the correct alternative. And so, 1. The classic scale pattern of frontal fibrosing alopecia, lichen planopilaris, and FAPD is predominantly interfollicular. 2. Yellow dots, broken hairs, exclamation mark hairs, and silvery white scales are characteristic findings of alopecia areata. 3. Follicularis decalvans may present with hemattic or yellowish scamocross that are located both in the peri and interfollicular regions. Or all of the above alternatives are correct. It's okay? Oh, you can vote. Let's move. Okay, that divides the opinion, but let's see what's right. Divided. Okay. Still black. Perfect. So, follicularis decalvans may present with hemattic yellowish scamocrosts that are located both in perifollicular and interfollicular regions. Let's see some trichoscopy images. So, lichen planopilaris, when you see lichen planopilaris, you can see perifollicular scales, erythema, and small tufts. In frontal fibrosing alopecia, the most important findings are the absence of vellus hairs and peripilar scales. Here in alopecia areata, we can easily see the yellow dots, the black dots, the broken hair, and exclamation mark hair, but not that silver white desquamation. And in follicularis decalvans, it's more frequent to see scales in the perifollicular region, but eventually, sometimes we can see in the interfollicular regions too. But we can also see hemattic scamocross or yellowish scamocross. So, the final message, the take-home message are, and the first case that I brought, the first case brought a reminder of subclinical seborrheic dermatitis and the importance of treating it as part of the therapy for hair loss. The second case showed that anti-dandruff and anti-seborrheic shampoos may be beneficial for patients with other inflammatory scalp diseases such as psoriasis. And the third case highlighted trichodynia and FAPD, two relatively new conditions that need to be properly identified for correct diagnosis and management of the affected patients. So I want to thank my group of research, and I'm very proud to be part of this group of University of State of Rio de Janeiro, with whom we could publish more than 50 studies in the last 5 years, and assist lots of patients in our daily practice at the hospital. And I'm very glad to be part of this team. Thank you all. Merci, Dr. Stefani. Grazie, Professoressa Piracini. Thank you all, and muito obrigado.
So we talk about two inflammatory scaling conditions of the scalp. So seborrheic dermatitis, psoriasis, and dandruff. So what do these conditions have in common? Of course, three things: the inflammation, the scaling, and the itch. So beside the cause, of course, we know what psoriasis is, what seborrheic dermatitis is, but the final end clinically is present of inflammation, dandruff, and itching. And the course is chronic relapsing, and of course, in all these conditions, we have the patient experiences a severe emotional distress, and compliance to most of the treatment is very low, because when you have to apply in a hairy area a cream or an ointment or a solution, the compliance gradually decreases with weeks or even days. So we all know that seborrheic dermatitis is very bothering to patients. There are several studies that show that despite severity of the condition, the itching and the presence of scales on the hair and on the dresses is really bothering for the patient and decrease the quality of life. This is especially seen in females. And the same applies to scalp psoriasis. The quality of life of patients with eye psoriasis is really influenced by the visibility of the part of the body. So it's not the knee of the eyebrow psoriasis. It's very evident, and these scales are difficult to cover, especially when the patient is not yet treated. And then again, difficulty to apply treatment. The common treatment that we utilize vehicled for the skin are not easy applicable to the scalp, and these lead to poor adherence to treatment and frustration. And the patient think that all drugs for psoriasis are not effective on the scalp. Scalp psoriasis is not uncommon. It is present in about 4/5 of patients with skin psoriasis, and the scalp localization may be the first one you diagnose before progression to other body areas. But 25% of patients have scalp psoriasis not associated with the skin condition, and sometimes it may be associated with arthropathic psoriasis, as the scalp is a risk area for having an associated arthropathy. Of course, scalp psoriasis has a cosmetic damage, a functional damage, and as I told you before, is difficult to treat. The symptoms are not only objective, so scales, but subjective, as the only site where psoriasis is itching is the scalp. Here you see the different presentation of scalp psoriasis. Of course, you can have the plaque that you see on the non-hairy area of the body. Also, you can see them in the scalp, and they go above the hair line. You can have the psoriatic shells, but you can have mild forms of scalp psoriasis, evident as thin scaling and seborrheic. And as Daniel showed you, trichoscopy is important for differential diagnosis in these cases. Less common forms of scalp psoriasis include the pustular form, scarring form of psoriasis, and pityriasis amiantacea. But as we saw before, inflammation due to scalp psoriasis often induces an increased hair loss, but appropriate treatment stops it. Seborrheic dermatitis is quite common, is the most common inflammatory disease of the scalp. It occurs especially in young patients, mainly in male, with typical recurrences during 2 seasons, April and September, so spring and fall. Of course, there are some categories of patients that experience a more severe form of seborrheic dermatitis, but you see inflammation, oily scales, and dandruff are a common feature of this condition that can be seen in the scalp and at the hairline. What is the cause of seborrheic dermatitis? There are several factors, intrinsic and extrinsic factors. And of course, you see, the sebaceous gland activity is impaired. You know that the scalp is very rich of sebaceous gland that can produce a sebum altered in quantity or quality. The barrier function of the skin is impaired, and this leads to a change of the scalp microbiome. This is a new evidence of the last 10 years. You know that the microbiome has been extensively studied in different parts of the body, and this is particularly true for the scalp, which is rich of sebaceous gland and so have a very rich microbiome. This change induces inflammation of the scalp that may be exacerbated by several factors. So here you see that the triggering of seborrheic dermatitis all act into seboproduction, inflammation, and the scalp microbiome. The scalp microbiome is particularly evident in the upper part of follicular ostium, where the sebaceous gland opens and the sebum gets in contact with the interfollicular skin. Of course, the scalp microbiome interacts with keratinocytes, and that as it roles in defending the scalp from infections. But of course, there is a balance between a normal sebum production and a normal scalp microbiome. This is a study that have studied the composition of scalp microbiome, and it has shown that we have both bacteria and fungi, yeast, on the scalp. The percentage of bacteria is mainly characterized by Propionibacterium acnes, while Staphylococcus is in minor percentage. While among fungi, of course, we have Malassezia, and especially Malassezia restricta, which is representative of the majority of yeast on a normal scalp. What happens in dandruff? You see, we have major changes in both bacteria and yeast component. In the yeast, you have an increase of component of Malassezia that increases in percent in the whole scalp. And among bacteria, you have a reverse percentage. So you have a decrease in Propionibacterium acnes versus an increase of Staphylococcus aureus presence. So overall, you have an increased ratio Malassezia restricta, Propionibacterium acnes, which is considered a protector of a normal microbiome. And again, Propionibacterium acnes decreases compared to Staphylococcus epidermis. So you see how a dandruff scalp has a microbiome which is considerably different from a normal scalp microbiome. So here you see what we now know as an evidence. The major fungal species in the scalp is Malassezia restricta, and it increases in dandruff, but also an imbalance of the bacterial component of the scalp is present in dandruff. But what about what happens with this? This changes the inflammation of the scalp. The changes of the scalp microbiome induce increased production of cytokine and decreased production of protective factor with increased inflammation. So redness, itching, dandruff, and hair loss. So these are all the changes at a molecular level. So what should we do to treat scalp seborrheic dermatitis? Of course, we should try to reverse to a normal scalp microbiome the condition of a dandruff scalp. So we have to decrease Malassezia, so antifungal agents are necessary, but we have also to restore the normal balance between Staphylococcus and the other bacteria. And so several molecules, especially selenium disulfide, has been shown effective in this restoring of this microbalance of bacteria. But there is increasing evidence that even acute recurrences of scalp psoriasis may be due to an altered microbiome of the scalp, and some evidence come from the fact that treatment with systemic or topical antifungal decreases these acute relapses of scalp psoriasis. So, what is the result? That together with the scalp inflammation, scaling and itching, and a chronic condition which impair quality of life of patient, dandruff, psoriasis and seborrheic dermatitis also have in common the need to rebalance the scalp microbiome. And if you look at treatment for scalp psoriasis in mild, moderate and severe forms, we always have a topical treatment associated, which is indicated since the beginning, and it is utilized as maintenance treatment when you have remission. The same applies for seborrheic dermatitis. In mild to moderate form, topical treatment is the first choice therapy, while it is associated with a choice of systemic treatment in severe form, but it is maintained for keeping low the inflammation when the patient is improving. So the target of topical therapy in both psoriasis and seborrheic dermatitis are in a way similar. You have to decrease the itching, you have to decrease inflammation, and you have to restore the microbiome balance. And in fact, together with the corticosteroid or vitamin D derivative more for psoriasis, in both conditions we use keratolytic to remove the scales, we use agents to decrease itching, and antifungal and antibacterial are now present in the most effective treatment for dandruff and seborrheic dermatitis of the scalp. Do not forget that you have to choose the right vehicle, otherwise patient compliance to therapy decreases. And that's why 60% of the product described are not used by patient. You see the typical patient who is asked to wear a cap with underneath a gel with some active agent for 3 hours. Of course, after a while, she stops treatment. And so these are the complaints that the patient claim. Poor cosmetic effect because they are difficult to be removed, so the greasiness that remains on the hair, and the time consumed for the application of most topical treatment. So when we treat erythematous desquamative dermatitis of the scalp, you have to find the right molecule and the right vehicle. And we now know that the right vehicle for the scalp is a shampoo. So we combine efficacy and compliance to therapy, which result in effectiveness and patient adherence to treatment. So here you see all these treatment molecules may be put together in a shampoo, having both efficacy and compliance. So we can have several phases of treatment. The treatment phase where you can reduce the malassezia load with antifungal vehicle in a shampoo or administered systemically. Then the maintenance phase needs antifungal, but especially antibacterial agent, in order to restore the normal percentage of bacteria on the scalp and keep low malassezia restricta scalp colonization. And here you see the change in the microbiome before and after this approach. Antifungal agent before and then antibacterial in the form of selenium disulfide shampoo in patient treated effectively with the psoriasis and scalp seborrheic dermatitis. So having a shampoo helps your life. Thank you.
So now I'm ending this presentation. So thank you first, everyone, for coming. Thank you to our great speakers and their great talks. So you know that Vichy Laboratoire with Dercos are really dedicated first to education of healthcare professionals, of course. And we have Dercos Scalp and Hair Academy deployed locally in every country now in partnership with local hair societies. And we also have a development which is more global, online in our scientific platform with on-demand content created by great experts, created by Bianca Maria and Daniel, for example. So now you can find Dercos Academy on our website, l'orealdermatologicalbeauty.com. You can have the QR code and you will have it at the end of the presentation. You can find content on scalp and hair science, dandruff and seborrheic dermatitis, of course, hair loss, trichoscopy, congresses and events are also actualized, and you will find newsletter with what's news, congress highlights also by experts attending the congress, interviews, training, patient leaflets, and of course clinical cases. So how can we with dermocosmetic shampoos improve the symptoms of the patients and their quality of life in chronic inflammatory dermatosis leading to scaly scalp? First, let's start with seborrheic dermatitis. As Bianca Maria said, of course, we know that there is a causative link between the application of a shampoo that will contain effective antifungal agents, reducing malassezia, such as zinc-pyrithione, ketoconazole, and so on. It will lead to a reduction in scalp and skin flaking. But we know that the cessation of treatment will lead to an increased level of the flaking. And what about the other scalp microbiome actors? So with Dercos Anti-Dandruff DS, we offer a complete formula. Selenium disulfide has a broad spectrum efficacy on scalp microbiome. We also have agents exfoliating dandruff, salicylic acid, vitamin E as an antioxidant role, and ceramide R to reinforce skin barrier function, which is altered in seborrheic dermatitis. So, of course, we can use it in monotherapy, and we know that selenium disulfide is effective on dandruff, and as you see, we have a remanent efficiency until day 73. This was presented last year at EADV. Here you can see these beautiful clinical pictures provided by Dr. Capeta, and you can see that very quickly, after 7 days, we have a strong efficacy. Selenium disulfide in monotherapy is able to rebalance the full microbiome. You can see here with a placebo shampoo, initially, the disbalance of the scalp microbiome, and after using selenium disulfide, you can see that very quickly the microbiome is rebalanced and comparable to a healthy scalp. In monotherapy, we show this extended effect on microbiome. As you know, in these chronic diseases, we have frequent relapses, and we need to have a maintained effect. So we can maintain the effect on flaking, but also on the microbial actors. In monotherapy, we are also efficient on the sebum composition, and we are also able to improve skin barrier by decreasing the transepidermal water loss. So Bianca Maria already presented you this article we published this year, which is an article of the use of Dercos DS after a post-ketoconazole treatment. We have an antifungal efficacy, so you can look here after the shampoo with selenium disulfide. We can maintain the pressure on Malassezia restricta until day 84, and we are also able to decrease the Staphylococcus until day 84. So large spectrum efficacy and maintained effect on the key players of microbiome. And what about psoriasis? Well, we have now Dercos Solution shampoo. Dercos Solution is containing 5% of urea and also salicylic acid to help reduce the scale, 1% of glycerin to restore scalp hydration, and also pyroxanolamine for the soothing efficacy. But also, as Bianca Maria showed you, there is also a microbial disbalance in psoriasis, so we added this antifungal treatment. Of course, as Bianca Maria showed you, we have a lot of patients that are not compliant to the treatment because topical treatment is difficult in scalp psoriasis. And we conducted first this study. This study is a poster to this year at EADV, so you can find it on the computers. And the study is a monotherapy to see the effect of solution versus its vehicle. So this study wanted to evaluate the efficacy of the shampoo, but also to assess the tolerance and the acceptability by the subject. And it lasted 30 days. First, we evaluated the PSSI, which is the Psoriasis Scalp Severity Index, assessing erythema, induration, and also desquamation. And you can see that here, after 30 days, we have significant reduction of the PSSI, even after 1 week. We also evaluated Scalp Dex. So Scalp Dex is the equivalent of the DLQI, but for scalp, assessing 23 items in 3 main dimensions: symptoms, emotions, and functioning. And you can see here examples of items that are assessed with Scalp Dex. And we can show that with solution, we also have an impact on the quality of life concerning symptoms, emotions, and also functioning. The assessment by the evaluator was also very good, with a significant improvement at day 15 and day 30. And concerning self-assessment, you can see that most of the patients were satisfied with the product and wanted to continue it. So, as you know, of course, in psoriasis, in the moderate form, we can use monotherapy, but in the most severe, we have to associate them with drugs, and topical drugs are not so well tolerated because they leave residues with a greasy aspect. So we choose to test the association with betamethasone and calcipotriol, of course, because it is one of the most effective topical therapy. It is widely prescribed, and that this compliance is difficult due to the greasy aspect of the shampoo. You can see here the design of the study. And first, when assessing PSSI, you can see a significant decrease, and since the first week, of course, much better after 2 weeks of use. You can see a great effect on desquamation also. On seborrhea, you can see that scalp seborrhea is better, but hair seborrhea is not affected. It's not leaving the hair so dry, and the shampoo had good washing properties. Here, in the clinical symptoms, you can see that all discomfort sensations decrease significantly concerning itching, stinging, burning, and irritation also. You can see also that we have a strong effect on all the parameters of Scalp Dex: symptoms, emotions, and functioning. So the patient's satisfaction was high, and for the volunteers that already use betamethasone and calcipotriol before, most of them said that the combination with the shampoo solution was more efficient than other combination they tested before. So in conclusion, the precise knowledge on scalp physiology and microbiome is helpful in managing inflammatory chronic scalp diseases, and Dercos innovation are able first to control scalp microbial disbalance, maintain this effect to improve efficacy and avoid relapse, both in monotherapy but also in association to the reference drug. It also improved the symptoms and the quality of life of patients with inflammatory scalp diseases. And I let you with the QR code. So if you want to connect to L'Oréal Dermatological BeautyPro.com and read more content about scalp and hair disorder. Thank you, and thank you for attending.